Welcome. If you are enjoying this lesson, please like, share, and subscribe to this channel. And share it with friends for this free course on Decode Healthcare with Harshal. Okay, imagine for a second that a hospital's entire financial survival could hinge on a single, seemingly insignificant missing word in a patient's medical chart. Sounds dramatic, right? But honestly, in the world of hospital finance, this is an everyday reality. A simple omission, like a doctor forgetting to write the words "with COPD" next to a pneumonia diagnosis, can literally cost a hospital thousands of dollars in lost revenue for care they actually provided. Today, we're going to figure out exactly how this complex system turns clinical documentation into actual hospital revenue.
To really understand how this works, we need a roadmap. We'll be looking at revenue cycle basics, decoding the IPDRG architecture, the real impact of comorbidities, demystifying the principal diagnosis, mastering ICD-10 coding structures, and finally, tying clinical documentation directly to revenue.
Section 1. Revenue Cycle Basics. The big picture. All right, let's dive right into this. Before we get lost in the weeds of coding, we really have to understand the environment we're operating in. At the absolute core of inpatient hospital finance in the U.S. is the IPDRG. That stands for Inpatient Prospective Payment System Diagnosis-Related Group. Think of it as a complete paradigm shift from how you'd normally pay for things. Instead of an a la carte menu where a hospital bills you for every single Tylenol, every X-ray, and every minute of nursing time separately, the hospital is reimbursed a fixed, flat amount based on grouped cases. So if patients have similar clinical characteristics and are expected to use similar hospital resources, they get put into the exact same bucket. And here's the real kicker. It's actually kind of wild. That payment amount is largely fixed before the patient is even discharged.
When you look at the entire life cycle of a patient encounter, you can clearly see where this crucial grouping happens. The journey kicks off with patient access, then moves right into care delivery. That's where all those diagnostic tests and physician notes get documented in the electronic health record. But look over at Phase 4, coding and grouping. This is the magic moment, right here. This is where clinical care gets translated into standardized codes, fed into a software grouper, and totally transformed into a specific payment group. It is literally the bottleneck of the entire revenue cycle.
And because the stakes are so incredibly high at that bottleneck, getting the DRG right is a highly collaborative team sport. You have medical coders, they're the ones analyzing the charts to assign the exact diagnosis and procedure codes. But they rely heavily on CDI specialists, or clinical documentation improvement teams. These folks concurrently review the charts while the patient is actually still in the bed, making sure the provider's notes fully support the codes being billed. Finally, the billing team takes those validated codes and submits the UB04 claim. If any one of these stakeholders drops the ball, the hospital is looking at either compliance penalties from overcoding or massive revenue losses from undercoding. Section 2. Decoding MSDRG architecture. Building the group.
So you're probably wondering, how does this grouping software actually decide which bucket a patient belongs in? Well, it's essentially a massive logic engine, and it follows a very strict step-by-step process. First up, it identifies the principal diagnosis, which anchors the patient into a broad family of diseases. Second, it scans all the secondary diagnoses to check for any complications or comorbidities that would make this specific patient harder to treat. And third, it checks to see if any major procedures were performed.
That third step leads to an immediate fork in the road. Based on that principal diagnosis we just talked about, a case is placed into one of 25 major diagnostic categories, or MDCs. But right away, the grouper splits the cases within that MDC into two very distinct partitions, surgical or medical. If a significant operating room procedure was performed, let's say an appendectomy, it goes down the surgical path. If no major OR procedure happened, it stays on the medical path. And as you might guess, the surgical partitions naturally carry a much higher baseline reimbursement, simply because of the immense resources an operating room requires.
Section 3. The impact of comorbidities. Severity matters.
But keep in mind, the baseline DRG is really just the starting point. To figure out the final payment, the system absolutely has to account for how sick the patient actually is. Severity matters. Check out this DRG triplet structure. Almost every base DRG is split into 3 payment tiers based entirely on secondary diagnoses. Down at the bottom, you have cases without CC/MCC, meaning a standard, uncomplicated stay. But if the coder finds documentation for a CC, a complication or comorbidity, boom, you jump to the middle tier. And if there's documentation for an MCC, a major complication or comorbidity like acute renal failure or sepsis, the relative weight of that DRG absolutely skyrockets. This secures the highest possible payment tier to cover the intense resources that patient consumed.
Now, this brings up a really critical question. What happens if a patient comes in for a routine procedure, but a severe complication, like a deep vein thrombosis or sepsis, develops after they are admitted? Does the hospital still get that high MCC payment bump?
Well, the answer lies in present on admission, or POA indicators. Every single diagnosis code has to carry a POA flag. If a condition was present when the patient walked through the front doors, it gets a Y. But if that deep vein thrombosis developed, say, 2 days into the hospital stay, it gets an N for not present. Under Medicare rules, an N indicator means that condition is considered a hospital-acquired condition. The grouper will recognize it's an MCC for sure, but it will generally refuse to use it to increase the DRG weight. So the hospital just has to absorb the cost of that extra care entirely, which is a direct hit to revenue.
Section 4. Principal Diagnosis Demystified, the Anchor Code.
We've talked a lot about secondary codes, but everything relies on this foundation. Let's figure out the single most critical input, the principal diagnosis. This right here is where hospitals absolutely bleed revenue due to simple misunderstandings. There is a massive, strict difference between the primary reason for admission and the principal diagnosis. The primary reason is the symptom the patient walked in with, like severe chest pain. But the principal diagnosis is formally defined as the condition established after study to be chiefly responsible for the admission. So if a patient comes in with chest pain and testing proves they actually had an acute myocardial infarction, the principal diagnosis is the acute MI. If a coder simply uses the admission symptom of chest pain, the software places the patient in the wrong major diagnostic category entirely, and that leads to a catastrophic underpayment.
Section 5. Mastering ICD-10 coding structures, the gears of the system.
Let's move on and see how this builds into the specific mechanics of the coding systems themselves. We're essentially looking at the gears that drive the entire machine. While diagnoses use the ICD-10 CM system, inpatient procedures in the US use ICD-10 PCS. And let me tell you, it is incredibly rigid. Every single procedure code is exactly 7 characters long. It's alphanumeric and completely combinatorial, meaning there are absolutely no decimal points. Each position means something very specific. Character 1 is the section, 2 is the body system, 3 is the root operation, 4 is the body part, 5 is the approach, 6 is the device, and 7 is a qualifier.
To build just one single code, a coder has to sift through dense operative reports to identify exactly which of the 31 root operations was performed. Was it an excision, where only part of a body part was cut out? Or maybe a resection, where the whole thing was removed? Was the approach open, or was it percutaneous endoscopic? The clinical documentation must be exquisitely exact. Why? Because any ambiguity means the coder simply cannot lock in the correct character values.
Just think about the vast possibilities generated by the very first character alone. The section character defines the broad category of the procedure. Character 0 represents the massive medical and surgical section. But if the procedure was an imaging service, it would start with a B. If it was physical rehabilitation, an F. The complexity is just staggering, and it all rests completely on the precision of the physician's notes.
Section 6. Clinical Documentation and Revenue, the Real-World Impact.
Okay, now that we understand the architecture, the severity tiers, and the rigid mechanics of the coding, let's tie everything we've learned back to the real-world financial stakes. Let's say a patient is admitted for pneumonia. They also have a history of chronic obstructive pulmonary disease, or COPD, which the nurses are actively monitoring and treating during the stay. If the doctor's discharge summary simply says pneumonia, the case is grouped as simple pneumonia without CC, yielding an expected reimbursement of around $6,200. But if the doctor had clearly documented pneumonia and COPD, that COPD acts as a comorbidity, bumping the tier to simple pneumonia with CC. The reimbursement suddenly jumps to $8,500. The exact same clinical care was provided, the exact same hospital resources were consumed, but vague documentation resulted in a direct $2,300 loss.
And this brilliantly illustrates why clinical documentation improvement teams are so vital. When a CDI specialist sees a patient is receiving breathing treatments, but the COPD isn't formally documented as an active condition, they intervene. The system generates a query, often a simple multiple-choice template sent directly to the physician's inbox within the electronic health record. The physician clarifies the record while the patient is still in the hospital. The coder gets the specific text they need, and that revenue gap is closed before the bill ever drops.
$2,300. That is just a single example. One patient, one missing comorbidity, one unseen revenue leak. So I want to leave you with this to think about. If one missing phrase can cost over $2,000, how much unseen revenue is lost daily across an entire hospital system with hundreds of discharges a day simply due to documentation ambiguities? Understanding the IPDRG system isn't just about administrative compliance. Accurate coding is the ultimate bridge between providing excellent clinical care and ensuring the financial survival to keep the hospital doors open. That wraps up today's lesson. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. See you next time.